Hi, everyone. Welcome to the second annual University of Michigan Injury Prevention Center Research Symposium abstract session on opioid and overdose. Thanks for joining us. We're so glad you're spending some of your Friday afternoon here with us. So I'm Dr. Donovan Most. I'm an associate professor of psychiatry here at the university, and I'll be moderating this session. As a reminder, the session is being recorded. Only the presenters and the moderator will be visible. The chat is disabled, so please use the Q&A feature in your Zoom menu for all questions. And please do ask questions of our presenters. If you could type them in the Q&A, if you could also please include the name of the presenter, that'll help us when we get to the end, after all the abstracts have been presented. That'll be our Q&A time. Again, put your questions in while the presenters are talking, include their name, and then at the end, we'll try to get through as many of them as we have time for. Each presenter will have 5 minutes to present their abstract. Their slides will be shared while they're presenting. Just as a reminder that all the abstracts can be found on the Center's Symposium webpage. There are 3 other abstract sessions that are occurring right now at the same time, so we have some competition. As much as we would like you to stay in this session to hear these great presentations, please feel free to visit the other sessions. And again, all the abstracts are available on the website, and recordings of all sessions will be released in the coming weeks. So now we'll go to our next slide where we have all the presenters listed. I think we have enough time that everybody's going to do their own introduction when they begin their presentation. Presenters, just a reminder that when it's your turn, do go ahead and please turn on your audio and your video, and then obviously turn them off once you're done. So at this point, I think we'll actually go ahead and dive into the presentations. Since I'm the moderator, that let me pick, and I'm going first, so then I can just listen to everybody else and get mine out of the way. So great, very good. Yep, go ahead to the next slide, Shiru. So my project is called Risk of Overdose Event Among Incident and Prevalent Benzodiazepine Users. So I'm a geriatric psychiatrist, really interested in safe and appropriate prescribing to older adults. While there's been lots of attention on opioid prescribing, benzo prescribing has kind of flown under the radar. These are medications like Ativan or Xanax. They're incredibly commonly prescribed, in particular to older adults. And we know that they actually are a common prescription medication that's involved in overdose. And so wanted to bring a little bit more attention to the topic to sort of compete with the attention of opioids. My co-investigators include Dr. Goldstick and Dr. Bonnert, who are both investigators with the Injury Center, and then Julie Strominger, who's the exceptional data analyst that I work with. Next slide, please. So kind of just to give you a little bit of context, big picture here, benzos are very widely prescribed. We've known about safety risks for a really long time, but prescribing in the community really hasn't budged, hasn't gone down at all. So the risks of benzo use compared to no use are pretty well established. The idea with this analysis was to look specifically among people who are prescribed benzos. And when we understand specific risk factors, both of the benzo prescription as well as other medications that they're currently prescribed that are associated with overdose risk. So we use a sample of Medicare beneficiaries, both disability, so those are younger beneficiaries, and older beneficiaries, so those would be adults 65 and over. We looked over about a 2-year period from 2013 to 2015, and we looked at 2 different groups. New benzo users, so we looked at a prescription. If you didn't have a prescription in the preceding 6 months, we put you into the new user bucket. If you got a prescription and you had received a prescription in the preceding 6 months, we put you in the prevalent, or really more accurately, the continuing bucket. And then our outcome of interest was an overdose event. So this both included an adverse reaction to the medication, as well as a overdose, both intentional and unintentional, within 30 days after that prescription. We look specifically at characteristics of the benzodiazepine prescription that were received, as well as opioid and other psychotropic medications that were sort of on board at the time that that benzo was prescribed, again, to really help clinicians get a sense for what are risk factors for overdose, short-term risk factors for an overdose within 30 days. We stratified our analysis by age, so 65 and over versus younger than 65, because there are potentially some important differences between those groups. Next. And just a reminder here again is this is not comparing benzo use to non-use. This is everybody's on a benzo, and we want to get an idea of what features or characteristics of those on benzos increase the risk of an overdose. Next, please. So here's the thing to highlight, I just want to focus on. So kind of the party line around benzos is that long-term use is not safe, but short-term use or shorter use is better. So I've always kind of questioned that, because benzos are basically like alcohol. You know that if you're not a drinker and you have one drink, you find that sort of more intoxicating, you're more likely to get a buzz than if you have a glass of wine every night. The effects of that glass of wine are really not so pronounced. And so my kind of hypothesis was that actually smaller supplies of benzos would be increased with increased overdose risk. Here, if you squint, you can look at those Kaplan-Meier curves. So it's days on the bottom and the probability of survival on the y-axis. And basically in all of those, so those are our four cohorts: new use, continuing use, young age, old age. The bottom line, the lowest survival, are those who received a less than 2-week prescription of benzos. Next, please. So we also looked at co-prescribed medications. So we know that opioid use increases risk of overdose, but we also found that co-prescribed antipsychotic use essentially is associated with a similar increased risk of overdose. And next, please. So that was a whirlwind overview of a big analysis with many, many people in the cohorts. But long story short, this is challenging the conventional wisdom that a short-term prescription is safer. In fact, we saw the opposite. Short-term exposure was increased, associated with increased risk of overdose. And then this is just broadening the concern about co-prescribing of other medications from opioids to also include antipsychotics. So a benzo antipsychotic is also associated with increased overdose risk. And so that's it for me. And our next presenter will be Elizabeth English. Go ahead, Elizabeth.
Hello, my name is Elly English. I'm a clinical subjects coordinator with the Michigan Opioid Prescribing Engagement Network, or Michigan Open, here to discuss our program that provides naloxone kits to patients at risk for opioid overdose in the emergency department. Next slide, please. So in 2019, 1,647 Michigan residents died from an opioid overdose, about 5 residents per day. The impact on the state is unevenly distributed. Wayne and Genesee counties do have some of the highest opioid overdose death rates in the state, both around 35 per 100,000 residents, compared to the statewide rate of 18.2 per 100,000. So as seen in the chart from their 2021 opioid strategy, MDHHS has identified the expansion of naloxone distribution as a key intervention to turn the tide on the opioid epidemic. Naloxone is an opioid antagonist, which rapidly reverses opioid overdose. The mortality risk of patients who are treated in the emergency department for a non-fatal overdose is high, particularly within the first 2 days post-discharge. So emergency departments are an ideal but underutilized clinical setting to implement harm reduction strategies like naloxone distribution to reduce opioid-related fatalities. Open collaborated with the Michigan Emergency Department Improvement Collaborative in 2019 to begin this program to distribute naloxone kits to patients at risk for overdose in 23 emergency departments across the state. We initially recruited 9 sites in cohort 1 with a focus on Wayne and Genesee counties per MDHHS's request. Additional 2-year funding was received in October 2020, and we recruited another 14 sites for cohort 2. Next slide. This map depicts the 23 ED sites recruited to date. The sites were recruited primarily based on geographic diversity throughout Michigan, ED patient volume, and county overdose fatality rates. Each site identified physician, nurse, and pharmacist champions to participate in the project. Our team conducted training sessions with each site, mostly with the nursing staff, about naloxone administration and how to communicate with patients about naloxone. This image on the bottom left corner shows one of the 6,800 naloxone rescue kits we have assembled. Each kit contains a pair of gloves, a CPR face shield, 2 doses of naloxone, as well as educational materials that were developed by our team, including a naloxone brochure with information about naloxone administration, and a county-specific pharmacy access card with information about where patients can purchase more naloxone in their county, as well as harm reduction agencies in their area. So ED staff screen patients to identify those at risk for overdose, distribute these kits, and then submit kit distribution data back to our project team. Though we are currently not recruiting additional sites to participate in the project, we have developed an ED naloxone distribution implementation guide to assist hospitals in implementing their own programs. Next slide. So since March of 2020, our sites have distributed 1,873 naloxone rescue kits to patients who are at risk for overdose. As of the end of this October, we've actually crossed the 2,000 kit mark. Some of our keys to success included identifying physician, nurse, and pharmacy champions for the project at each site. And we lead monthly site champion calls and encourage collaboration between our cohort 1 and cohort 2 sites to troubleshoot and overcome logistical barriers. Lastly, we create detailed visual monthly data summaries to provide feedback for our site champions on their kit distribution. To our knowledge, we are only the second state with a statewide ED take-home naloxone program. We've demonstrated that the implementation of an ED-based take-home naloxone program in Michigan is feasible, and that the emergency departments are an ideal setting to implement these harm reduction strategies and reduce opioid-related fatalities. Thank you very much. And thank you to the Injury Prevention Center for allowing me to share our work.
Hi, everybody. I'm Emily Passman. I'm from the School of Social Work at Wayne State University. I wanted to first acknowledge my co-authors, Dr. Keejan Lee, who'll be presenting for us next year, as well as Danielle Hicks and Drs. O'Shea, Brown, and Resco. I want to also thank our funders at SAMHSA and MDHHS and our partners at Families Against Narcotics for their support. So this study examines factors associated with knowledge and attitudes toward naloxone among family members of people with opioid use issues. As was just discussed, naloxone is a drug that is approved by the FDA to reverse opioid overdose, and initiatives to increase access to naloxone have grown enormously in recent years. They've been shown to be very effective in preparing laypersons to manage opioid overdose. However, we also know that these programs might not be reaching the family members of people who use opioids. Now, family members are a very important target for naloxone initiatives, and that's because many opioid overdoses occur at home, so family members are often the first to discover that an overdose has occurred, and therefore best positioned for timely intervention. There have been a few evaluation studies that have looked at naloxone training outcomes among affected family members, but we know a lot less about the knowledge, attitudes, and experiences of family members outside of training settings. Next slide, please. So we partnered with treatment providers and support groups throughout the state to survey adults who had a loved one that had experienced opioid-related problems. So those that had a sibling or step-sibling, a parent or step-parent, a child or a spouse with opioid-related problems were eligible to participate. We looked at demographics, family overdose history, perceptions of medication for opioid use disorder, and naloxone training experiences. For our outcome, we used abbreviated versions of validated scales to examine knowledge of opioid overdose risk, signs, and care, as well as self-efficacy and willingness to respond to opioid overdose. We then used multiple logistic regression to identify factors associated with knowledge of opioid overdose and attitudes toward opioid overdose response. Next slide. So our participants ranged in age from 18 to over 65, averaging about 46 years old. The sample was predominantly female and white, though we had about 14% who identified as a person of color. Just over half had a college degree. About half of our participants had a loved one who they knew had overdosed, and less than a quarter had a positive perception of medication for opioid use disorder. We had 38% of our family members that had received training on naloxone administration. So as we see in Model 1, those who were aware that their loved one had overdosed had greater knowledge of naloxone, and those who identified as a person of color had lower levels of knowledge. In Model 2, we see that older age, having a positive perception of medication for opioid use disorder, and receipt of naloxone training were associated with more positive attitudes toward opioid overdose response. And next slide. So these findings provide direction for mobilizing a largely overlooked population in response to the overdose crisis. Like many other studies before us, we found that completion of naloxone training was associated with greater self-efficacy and willingness to respond to opioid overdose. However, less than half of family members surveyed had received that training. Those who knew that their loved one had experienced an overdose had greater knowledge, but ideally we want to be reaching family members with this knowledge before an overdose occurs. Our findings also indicate a need for greater naloxone education among people of color and younger family members like adult children or siblings. So incorporating naloxone education into mainstream health and social services might help improve naloxone knowledge and attitudes among family members. This can include partnerships with healthcare providers, criminal justice professionals, and first aid training programs, for example. And it could also include population level interventions like public service announcements. By educating the broader populace about naloxone, these efforts would also help to reduce stigma, which is a major barrier to the reach of naloxone training programs. Ultimately, such efforts will help to prevent overdose fatalities and reduce the human and social costs of the opioid overdose crisis. Thank you.
Hello, everyone. Good afternoon. Thanks for coming in. My name is Kijin Lee. I am a postdoc researcher at Wayne State University. Today, I'm going to present risk factors for mixing alcohol and prescription opioid among young adults in Michigan. We are a substance use research team at Wayne State University, and this study was sponsored by SAMHSA and MDHHS. Next slide, please. Yeah. Alcohol can have serious side effects by itself, and it can enhance the side effect of prescription opioid when people use them together at the same time in more unpredictable and dangerous ways. The mixing use of alcohol and prescription opioid is emerging public health concerns these days. However, only few studies have investigated the simultaneous use of alcohol and prescription opioid. So this study examined the factors associated with simultaneous use of alcohol and prescription opioid use among young adults in Michigan. 1,751 young adults aged 18 to 25 in Michigan were recruited to complete an online health survey. Predictors measures we use for the analysis include demographic characteristics such as age, gender, race, ethnicity, and education level and their residential area. And we also include emotional well-being level, the past year use of prescribed pain relievers, knowing someone who died from overdose, the binge drinking frequency, and perceived risk of prescription pain relievers. For analysis, logistic regression of analysis were performed in M+ with the full information maximum likelihood method for dealing with missing cases. Next slide. As a result, we found some risk factors for mixing use of alcohol and prescription opioid. Among the demographic variables, we found that older age and lower levels of education were associated with greater odds of mixing use of opioid and alcohol. Among substance use variables, we found that more frequent binge drinking and more use of prescribed opioid pain relievers, knowing more people who died from overdose, and lower the perceived risk of opioid pain reliever were associated with greater odds of missing use of alcohol and prescription opioid. Lastly, we found that lower emotional well-being was associated with greater odds of missing use of alcohol and prescribed opioid. Next slide, please. Our study concludes that mixing use of alcohol and prescription opioid increase the risk of overdose and beyond. The current study improves on previous studies by assessing simultaneously use of alcohol and prescription opioid among young adults in Michigan. In the policy side, we suggest harm reduction approaches to increase education for explaining the risk associated with the simultaneous use of alcohol and opioid for younger adult population. That is it. Thanks for listening my presentation. And if you have any questions, please contact me. Thank you.
Hello, everyone. My name is Hala, and I am a public health educator with Access and part of the ASAP Coalition. And we will be looking at our partnerships in developing a prescription opioid overdose prevention approach. And I'm also joined by my supervisor, Mona Abdullah-Shazi. And next slide, please. So I'll begin by just looking a little bit at some of the methods that we used. And these involved the SAMHSA Strategic Prevention Framework and also CADCA's sorry about that. And then also the CADCA 7 strategies for community change. And then also these were very helpful in allowing us to begin our work in order to see what was needed in the community, especially the partnerships that we had developed. And these included some of our community sector partnerships. So this involved work with the local police department. We also did this to change the consequences of opioid overdose. And then this also is what really helped us with our SUD advocate program. And this is where we were able to connect anyone in the community who was in a substance use crisis and they needed resources. We wanted to change the consequences of that. And then also to see if instead of getting them to anyone who was using any substances or opioids, instead of punishing them, they would be given that rehabilitative approach. And then we also partnered with the school's athletic departments and also healthcare providers, pharmacies, in order to provide information about preventing opioid misuse. And then we've also taken a lot of part in Narcan trainings and done this to train community members to recognize any signs of opioid overdose and then to administer naloxone for overdose treatment. And we've also had our partnership with Michigan Open, or the Michigan Opioid Prescribing Engagement Network. And we work together on this digital marketing campaign and to prevent any opioid related harms by educating parents about the safe use of opioids, specifically for any adolescents that were undergoing surgery. And then we've also worked on modifying policies. This included any opioid misuse policies. We changed that physical design of the environment that was contributing to any overdose in the community. And this was with our partnership with the Southeast Michigan Alliance for Addiction-Free Communities and the Michigan Opioids Task Force. And then also some of our work with our projects and research. We participated in the CADCA Non-Opioid Choices Project, and we worked to spread awareness to the community on anything that was needed for non-opioid choices, getting more awareness out in the community, and then also seeking out the help of health providers and lawmakers to also support these initiatives. And we also conducted research studies to inform some new culturally sensitive prevention interventions. And next slide, please.
So hi, my name is Mona Hajazi, work closely with HELA. One thing that I want to mention is our work is funded through the CDC. So we are a drug-free communities coalition, and we are the first to serve the large population of Arab Americans in the US. So the city that we are located in, there is a very large population of Arab Americans, immigrants, refugees. and it's a very diverse population. Through our work, what we have been able to see is partnering with other organizations on our prevention efforts. We've been able to allow diverse viewpoints and contributions, increase capacity by sharing resources. We meet as a team once a month, and we discuss what's going on in the community, what are the needs. Of course, we focus on substance use, reducing it among youth and increasing community collaboration, but we know that sometimes we need to get involved in other community needs, for example, reckless driving. We've accomplished more together by combining our skills and our knowledge. We have reached out to other organizations, and we have worked by creating these projects by looking at the consequences that people face with substance use. Next slide. Heather.
And then just to conclude our work on this, we found that having partnerships in the community, especially with the different sectors, was really helpful because we were able to reach wider audience. We were able to gain more trust from the community members. And we were also able to tackle, prevent opioid overdose from different angles that we once weren't able to on our own. And also we learned that cultural sensitivity was very crucial. It guided all of our work and allowed us to respond to opioid overdose cases in a community that has a high stigma towards opioids and substance use. And we were able to, again, utilize that in order to maintain the trust of the community members. And then it would have been really difficult to develop these new effective injury prevention approaches if it wasn't for our partners. And finally, establishing and maintaining partnerships did require continuous effort. Once we established those partnerships, we had to continue to maintain that trust and that communication in order to continue our work. And thank you.
Hi, everyone. Thank you for joining us today. My name is Holly Gernick, and I will be presenting on the expansion of the Michigan System for Opioid Overdose Surveillance, otherwise known as SOS, and how it can be used to inform data-driven community responses to opioid overdoses. The two PIs for the project are Dr. Jason Goldstick and Rebecca Cunningham. Next slide, please. So the SOS system was first launched as a pilot project in one Michigan county and then was expanded across the state. And it worked really closely with stakeholders, in particular Washtenaw County and the city of Detroit, to design a system that is user-friendly and very accessible. So there are two main data sources for SOS. One of those is emergency medical services, or EMS, which is when a bystander usually calls 911 and then naloxone is administered to someone who is suspected of suffering from an overdose. Then the second data source is medical examiner records, or ME records, and that is when overdoses are the suspected cause of death. They can't be confirmed as the cause of death until toxicology reports are obtained. However, that takes usually about 4 to 12 weeks. And due to the near real-time nature of SOS, it's really important that those ME data is extrapolated almost daily and uploaded to the system. So for example, we have some stakeholders in Detroit who have mobile harm reduction units that they actually send out into neighborhoods of the city where they see suspected overdoses occurring, particularly a lot of deaths. And so it's really important for them to have that near real-time data so they can target their intervention with the trends that they're seeing at the current moment in their community and not 3 months from now. So then there are two ways to access the SOS system. It is a web-based tool. The first one is the public, it displays county level summaries of opioid overdoses over the course of the year. And then the second level is available to authorized public health and public safety users across the state of Michigan. And that maps the non-fatal, which is EMS, and fatal, which is ME, opioid overdose incidences in near real time. So one of the reports that those second level users would have access to is displayed on the screen. So there's a map of the county as well as a brief demographics of overdoses that have occurred. Next slide, please. So since it was initially launched in 2016, a lot of work has gone into communicating with other stakeholders who use the SOS system to improve the system so that it's better tailored to their specific opioid overdose response. So the first most recent improvement that was made was spike alerts, which is when stakeholders are allowed to set a threshold value using either EMS or ME data in a specific community of their choice. And then once that community sees that threshold value reached for the opioid overdoses, so say the threshold value is 20, if then there are 20 EMS reports of naloxone in that community, they will be alerted via email so that they're able to better respond to those spikes in their community. So for instance, flood the area with naloxone or something like that, just to actually try and prevent those overdoses from occurring. Another improvement that have been made is data overlays, which is when census data can actually be overlaid on the map of the community. And then stakeholders can also see naloxone outlets where they are placed on the map. Next slide, please. So timely opioid overdose surveillance in Michigan has really broad implications for both public health and public safety stakeholders. And as I mentioned, it really allows for that focused intervention and resource allocation in those at-risk communities. So having that data-driven response is really important to our stakeholders so they're really better able to tailor their own response. So there are two future goals for SOS. The first one is forecasting future overdose hotspots. So a good analogy for this is like a weather map. So for instance, if there's a big storm rolling in on a weather map, people will start to prepare for it. So, they'll go to the grocery store, stock up on food, gas. The state might call in other emergency vehicles just so they're better able to handle the aftermath of that storm. This would serve a similar purpose. Stakeholders would be able to see, okay, there's a particular time in my community where overdoses are more likely to spike, or a specific place in my community where overdoses are more likely to spike. And then they'll actually be able to respond ahead of time and try and prevent those overdoses from occurring instead of just responding afterwards. So then the second goal of the SOS system for the future is evaluating the enhanced surveillance. So that's actually seen as having access to near real-time data really translate to better outcomes. And then with having that hotspot forecasting really improve the effectiveness of opioid overdose response. Thank you so much for joining us today. And I hope you learned a little bit something about what SOS does in terms of opioid overdose prevention.
Hello, everybody. My name is Rachel Lenko. I'm a PhD candidate at the University of Michigan School of Nursing, and I'm excited to present today. I'm really hoping my power does not go out as it's super windy outside, so bear with me if I get choppy. So anyway, today I'm going to talk about our recently completed, earlier this summer, randomized control trial in which we sought to enhance risk perceptions in order to minimize prescription opioid use and misuse among adolescents and young adults. I'm presenting on behalf of a larger team. Our senior leader on this project was Dr. Bobo Lewis, and we were supported with funding from the National Institute on Drug Abuse. Next slide, please. See, okay. So prior work has suggested that exposure to prescription opioids during adolescence is associated with later opioid misuse as they age. The work of my senior author and others, previous research have shown that there's strong associations between prescription opioid misuse and lower opioid misuse risk perceptions among teens and young adults, which suggests that raising risk perceptions may be an effective strategy to curtail opioid misuse later on. So building on all of this work, our team developed an intervention called the Scenario Tailored Opioid Messaging Program, or STOMP, with the intention of enhancing the perceived riskiness of opioid misuse. And that what the intervention does is it asks participants to imagine themselves in situational scenarios days to weeks after a surgery, in which they've run out of their prescribed opioid but are still experiencing significant pain. And then participants are asked to choose among several available medication options that include borrowing a leftover prescription opioid from the medicine cabinet or from a friend, taking an over-the-counter medication, or doing nothing. And then once participants make those decisions, they're immediately given brief written and video messages with information that really emphasizes the risks of opioid misuse and opioid use in general. So with IRB approval and informed consent, or assent, depending on the age of the participants, we randomized 459 patients aged 15 to 24 years old to either routine information or, routine information plus our STOMP intervention. and all participants were scheduled to receive an opioid prescription to manage acute postoperative pain. We then assessed analgesic misuse risk perceptions at baseline, and this was before their surgery or any discharge education. And then we also assessed it at 4 time points through 3 months after surgery. We also assessed participants' pain experiences and analgesic trade-off preferences, which are the degree to which someone values the analgesic benefit or pain relief over avoiding risk like opioid risk. So we had 3 primary outcomes for this study. These were risk perceptions, self-reported post-operative opioid use, and then also misuse intentions or behavior. And these were measured both with decision scenarios, those that I mentioned before, and also self-reported behavior. Misuse included using somebody else's opioid or the patient's own prescription in a way that was not prescribed, either too much or more frequently. Next slide, please. So here's a little glimpse at our results. Controlling for participant characteristics, baseline symptoms, and past year substance use behavior, we found a significant but modest effect of the Stomp educational intervention on analgesic misuse risk perceptions over time. And risk perceptions were significantly higher on day 14 and month 3 for the Stomp group compared to the control group. However, despite the effect of the intervention on risk perceptions, there was no effect of either Stomp or risk perceptions themselves on postoperative days of opioid use or misuse behavior or intentions during the study period. Instead, opioid misuse behavior and intentions were explained by the postoperative pain experience. So as well as higher preference for analgesic benefit, that is if they prefer to have pain relief versus avoiding risk, and prolonged opioid use. Next slide, please. So here's our conclusions based on our study results. Again, our Stomp intervention that emphasized risk perceptions had no impact on our behavioral outcomes of interest, that is opioid use or opioid misuse. Rather, it appears that pain and a preference for pain relief remained significant motivators for these outcomes. So contrary to study hypotheses, risk perceptions were not enough to overcome symptoms. This contrary finding may be partially related to our use of a clinical sample rather than a community sample, as our participants were experiencing acute pain and thus potentially greater motivation for opioid use or misuse. And it looks like my time's up, so I'm gonna end here. And if anybody has any questions, I'm glad to hear them later on.
Hi, my name is Tiffany Wheeler, and I'm a clinical subjects coordinator in the Psych Substance Abuse Department. I've had the pleasure of working with Dr. Maureen Walton and Dr. Aaron Bonar on their study that focuses on the reduction and prevention of opioid misuse. This study is funded through the NIH HEAL initiative, which stands for Helping to End Addiction Long Term. And today I will be discussing correlates of prior substance-related overdose experiences among adolescents and young adults in the emergency department reporting recent opioid use. Next slide, please. So for our study, we screened individuals aged 16 to 30 presenting to the emergency department for any reason. They are eligible if they report past 12-month opioid misuse, which includes prescription misuse or illicit drug use, or if they report past 12-month prescription use plus a qualifying risk factor, which could be past 3-month binge drinking, marijuana use, other drug use, or other prescription misuse or illicit drug use. Those who complete baseline will then be randomized into one of our 4 conditions, which are a control group, a virtual brief intervention with one of our health coaches, 30 days enrollment into a portal messaging platform or both the portal messaging platform and a virtual brief intervention. Some other mental health related risk factors for eligibility are also a past 2-week depression screen, past 2-week suicide ideation, or a past year suicide attempt. Some exclusions for our sample are those who present to the ED for acute suicidality or sexual assault, or those who are pregnant or who are currently undergoing cancer treatment due to the distress and additional services that they're likely to receive when they're in the ED. Those who report injecting drugs or or at high risk of an opioid use disorder will be excluded and referred to treatment, since our study focuses more on prevention and may not best serve these individuals. So as you can see, out of the 1,732 patients that we screened, the majority of them had no opioid use at all, but almost 25% were eligible for our study. We had 277 participants complete the baseline at the time of creating this presentation, and 19.5% reported opioid misuse, with the remaining majority reporting opioid use plus an additional risk factor. So to describe some of those most likely risk factors that caused eligibility among our sample, over 75% reported alcohol use, over 60% reported cannabis use, and over 40% reported some other drug use. And nearly half of our samples screened had a positive depression screen. And some brief demographics of our sample: the mean age was 24, 27.1% were male, 17% identified as Black or African American, and 5% identified as Asian. Next slide, please. Next slide. Thank you. So for the purposes of this presentation, we decided to analyze those who reported having a lifetime prior overdose experience, which is defined as taking more of a substance than your body can handle, versus those who did not. And notably, we had 37.5 of our sample report that they had a lifetime overdose experience, with the mean number of times being 3.4. As you can see on this top table, we had some clinically significant differences between these two groups, with those who did report having a prior overdose experience also report having higher symptoms of depression and anxiety, more loneliness and stress related to the COVID-19 pandemic, and also more drinks on average per occasion. We then asked subsequent questions about the time that they had the worst experience with overdose. And some of the substances that they reported are here on the left, with the most common being alcohol, followed by cannabis, opioids, sedatives, stimulants, hallucinogens, and other. And 54.8% of our samples said that they used multiple substances. And on the right here, you can see some of the symptoms that were reported, with the most common being vomit and nausea, blackouts, their heart beating too fast or too slow, loss of consciousness, difficulty breathing, and 2.8% of our sample had naloxone during this worst experience. Next slide, please. So kind of what we took away from this, with 25%, almost 25% of those in the ED being eligible for this opioid prevention study, a third of them reporting having an overdose experience, and most of them being someone who had recent opioid use plus an additional risk factor, whether substance or mental health related, really highlights the need for prevention among emergency department patients specifically. And also looking at the differences between those who had prior overdose experiences and seeing that they had increased stress and loneliness, increased drinking, and increased mental health symptoms, it really supports the need for opioid prevention efforts to address polysubstance use and mental health concerns, coping strategies in relation to overdose experiences. Thank you so much.
Thanks everybody for those great presentations. Now we have plenty of time for a Q&A. I don't see any Q&As that folks have asked. So what I might do is just go through, and if the presenters want to go ahead and turn their cameras on, I'll go through a question for each of the presentations. And then if we have some questions come in, great, we can ask those. And if we don't, that's also just fine, and we can wrap things up just a little bit early on this Friday afternoon. So first, we'll start with Ms. English. So in your presentation about the naloxone kits, I was wondering, were there any particular indications for who would get those kits? And then could they potentially go to family members as well, or did they only go to the patient that presented to the ED?
Yes, so for the indications for kit distribution, there are 4 main ones that we have providers look for. The first is if they're treated for opioid overdose. Also, if they have a history of substance use disorder of any kind. If they're on chronic prescription opioids or benzodiazepines, that's an indication. And then if they were recently released from incarceration or a detox facility, we have them distribute kits to those patients as well. As far as receiving kits, any patient who comes in with any of those indications is eligible. They're only able to receive one kit per patient per visit. So if they come in for multiple visits, they are eligible to receive another. And then unfortunately, we aren't able to distribute to family members. We can only distribute to patients, but we do have extra educational materials and supplies for family members.
Great, thank you. And then that's actually, I think, kind of a nice segue to the next presenter, Emily. So what do you think are some reasons that naloxone training isn't higher and more common among family members of people who use opioids?
Yeah, so there's been other researchers that have used the cascade of care framework to look for gaps, excuse me, in naloxone distribution. So this is a framework that describes each of the steps that are required for a successful naloxone program. So individuals must first be aware that naloxone is effective. They must have access to it. They have to have training on how to use it, and then they have to have it with them and choose to use it in an overdose situation. So as a follow-up to the survey that I kind of discussed in my presentation today, we completed qualitative interviews with affected family members, and awareness of naloxone emerged as a really critical gap for this population. Many of the family members that we talked to hadn't heard of naloxone, or even if they had heard of it, they just hadn't considered getting it for their family member. And we did hear this more from family members whose loved ones were using prescription opioids under the prescription or under the supervision of a doctor. So that might be a key area for increased efforts. And then, as I mentioned briefly, stigma is a major barrier to the success of naloxone programs. So concerns about how one might be viewed or treated, or fear of legal repercussions could deter someone for asking for naloxone at a pharmacy or attending a community training. So I think reducing stigma towards naloxone and toward people who use opioids more broadly will be a really important part of efforts to increase the reach of naloxone programs.
Great, thank you. Weijin, in your work, why did you focus specifically on opioids and alcohol as opposed to other types of substances people might co-use with opioids?
Thanks for asking that question. Actually, it's a good point. The alcohol use and the prescription opioid use increasing day by day. But when people use the combination use of alcohol and opioid may bring more serious side effect. So that's why we are focusing on the combination use of alcohol and opioid.
And just to clarify, were you specifically looking for people who were using them both at the same time?
Yes.
Or they happen to use both, maybe not at the same time?
We are focusing on when they use the same time, the combination use. Yeah.
Great. Hala and Mona, I'm curious, in your work, can you give us a sense for the extent to which opioid use, the opioid epidemic sort of characteristics or features within the Arab American community might be different than sort of more broadly what we're seeing, and anything that you think is unique or different?
That's a good question. So I think for us, so we have a lot of there's a couple of things that we see. We have a lot of trust factors with physicians. So people really don't question when something is given to them or to their child. And it's like
trust, meaning it's very
like
high,
really high, like
okay,
like a little too high actually. Where even so we try to teach them about taking into consideration, questioning or even getting a second opinion. And we also have a huge problem of pill sharing, and it could be something as simple as like just Tylenol, Motrin, So we really work hard on explaining, because a lot of in the Middle East, it's a little, the way the medication is distributed is so different. So that kind of came over here. And so there's even we want to make sure that we are educating people about, not sharing their medications. And then like like other communities, what's happened is we've fallen into, just being a pill popping community versus alternative to care. And that's why we got on the CATCA non-opioid projects to educate people on holistic approaches. And we even had to like educate them on how holistic approaches do not hinder any religious or spiritual work. And so, yeah, there was that, but we even, when it came to our youth, the anxiety that a lot of our students have for overachieving and the use of Adderall, again, ADHD, there's just so many different avenues that we've seen come. And then we have a large population of people who have trauma. And so there is that as well. So yeah, that's, I think, is doesn't make us unique, but it's that what we are facing. But we just have so many people. We have like 150 pharmacies in our city. That's independent pharmacies outside of like Walgreens, CVS, and Target. So like it's intense. But yeah, that's stuff that we are facing as well.
Thank you. So moving on to Holly and the SOS system, what do you think is the value or the importance of having sort of real-time data in terms of overdose prevention?
Yeah, that's a really good question. So like I mentioned in like my little talk, the ME data, particularly because you can't, like the toxicology report is usually a few months delayed. So you can't necessarily confirm that it's an overdose until then. But that being said, like if you're responding in a community using that data that's like 3 to 4, 5, 6 months old, you're looking at really old trends. So you're not necessarily understanding what's going on in your community at the particular moment. So then you're always kind of playing catch up and you're responding to something that has already passed. So having that near real-time data is really important so that stakeholders can actually tailor their response to what's going on in the community at the current moment. And like a lot of our like improvements to the system have also been to try and help with that. So like the spike alerts, like when you actually get notified that there's a spike alert occurring in your community, that being said, you're just better able to kind of tailor your response because you understand what's going on. So you're not playing catch up, you're actually responding to what's going on in your community at the current time.
Great. It looks like actually Emily had a question for you. Emily, if you want to go ahead and ask it.
Oh, sure. So I know you said in your presentation that you're looking at evaluating outcomes as kind of a future goal, but I was just wondering if there was any preliminary data, if you have any sense of whether like the opioid overdose hotspots or outbreaks are resolving more quickly now that you're able to discover them more quickly and provide resources to that area more quickly.
Yeah, so that would be kind of like with like the spike alerts, which is relatively new. Like it actually was just launched at the start of this summer, I believe, at the end of summer. So like that data is still being collected. So I don't have any like specific numbers for that, but I can like follow up with you afterwards when we actually have those numbers if you would like.
Yeah, I just think it's so interesting and definitely needed. So yeah, great work.
I agree.
Rachel, could you tell us a little bit more about the Stomp intervention and how or why, if it's been used in other populations to impact decision making?
Yeah, it was actually, so the intervention that I talked about today that we used with adolescents and young adults, so 15 to 24 years old, was actually modified from an intervention that we used with parents. So Dr. Lewis, or Terry, she has, most of her work has been in pediatrics. And so she originally was really interested in like opioid safety for post-op kids. And so in that case, the intervention goes to the parents because they're the ones like managing their kids' pain. And in this case, part of why our age group started at 15 was because we were really interested in like kind of the stage when folks are starting to make those decisions for themselves rather than having their parents make those decisions. So yeah, so it was used for parents. There was more success with parents. It wasn't overwhelming, like, wow, look how much we've like affected their decisions. But there was enough that we thought, oh, cool, like let's try this with a younger population who's managing their own pain. And I didn't get a chance to say this in the presentation, but part of our wondering if the reason for this, the reason that we didn't really see significant outcomes was just because of our population. We were using a clinical sample with kids who were having a lot of pain, which is a lot different than a community sample, where ideally folks aren't in as much pain because I didn't just have surgery. So yeah, great question.
Thank you. And then Tiffany, last question is for you. Did you all look at differences, say, between intentional versus unintentional overdose?
So we didn't. We did see that the majority, or I believe it's like 60.8%, were accidental overdoses, and then around a little less than 20% where they didn't care about the risks. So not so much on purpose. And then we had like a small amount of people, around like 5%, that did report that it was on purpose, that they wanted to die and end their life. So we do have some like data, some small data about like the intentions that people had before they did end up having these overdose experiences, but we haven't analyzed any differences between those groups of people yet. But that would be a great potential future direction to look in.
For next year's symposium, you can come back and present those results.
Yeah.
So there aren't questions in the Q&A. I think that's okay, though. We can go ahead and wrap up a little bit early. Shira, if you want to, I think there's one final slide to put up. Great, thank you. So thanks everybody for joining us for this second annual Injury Prevention Center Research Symposium virtually again this year. Thanks to all the presenters and to our fantastic staff, Amanda and Shiru, for making sure that everything today went smoothly. Folks who've attended, you'll be receiving an evaluation survey in the next few days. We would encourage you to please fill it out to help us grow and improve the event for future years. And then also that enables you to request continuing education credits after you've completed the survey. Again, more information can be found out on the Symposium web page. If you're not already a member of the Injury Prevention Center, please go to the website at injurycenter.umich.edu to become one and get access to our monthly newsletter with publications, updates, and events. Please check out our website for more information and opportunities that may interest you or colleagues, such as our fantastic summer internship program or MOOC and massive open online courses. As a reminder, all the sessions today were recorded and will be available on our website in the coming weeks. Thank you again for your attendance. Thanks to all the presenters for presenting your work in injury prevention. Have a happy Friday and have a great weekend. Thank you all.
Thank you, everyone.